There we go. Oh, breaking everything.
Test mic 1, 2, test mic 1, 2. Test microphone 1, 2. Test, test.
Yeah, we're both decently local kids. I grew up in Laverne, so.
Oh, okay.
Test mic 1, 2.
Angeles County as you can get.
As you can get to the very end,
Yeah.
on the edge.
Test microphone 1, 2.
Some would say the IE with my 909 phone number.
Yeah. If I saw that, I'd be like, oh yeah, you're IE. I was bringing it up because I'm from Northern California. And it's a lot more rain and colder and temps there. Especially where I grew up, so. This reminds me of home.
Test mic 1, 2, test mic 1, 2.
Did you just doing COVID today?
I'm sorry?
Is she just doing COVID today?
Yes.
Okay.
Test mic 1, 2, test mic 1, 2.
No mpox, if that's what you're asking.
Yeah, no, I'm fine. Okay. I'm sure she'll talk RSV. Okay. And flu.
Yes.
Okay.
Okay, great. Good afternoon. Thanks so much for joining today. I hope that everyone had an enjoyable Thanksgiving holiday and time to gather with friends and family. Today I'll go over the most recent trends for COVID-19, flu, and RSV, along with our early alert signals. As expected, we are seeing changes as we enter December. I'll take the next slide. Each week I start with the updated trend lines for COVID-19 to give us an overview of where we are. Recently for this slide, we've been looking at changes since March of 2022, but today I'm showing trend lines from July of 2020, really looking at more than 2 years of data. On this graph, that green trend line is the 7-day average of the number of cases reported daily, and it's measured using the vertical axis on the left. During the past week, an average of over 2,700 cases were reported per day. That's an 85% increase from the 7-day average of nearly 1,500 cases reported per day as of November 17th. And it's a 180% increase over the past month since November 1st. As we've seen in the past with rising case counts, we also see an increase in the average number of daily hospital admissions. That's the orange line. This past week, there was an average of 192 admissions per day. Hospital admissions have increased 200% since November 1st. The higher rate of recent increases in hospital admissions when compared with cases likely reflects the undercount of positive cases using lab-reported data. With many residents using over-the-counter antigen tests to determine their COVID status, there are likely many more people who have tested positive for COVID than our case numbers are capturing. For perspective, we can go back to where we were a year ago. On November 30th, 2021, before the Omicron surge last winter, indicated by that tallest green peak on the graph, there were an average of 856 cases reported per day, compared to 2,483 yesterday. There was an average of 63 hospitalizations per day on November 30th of 2021, compared to 192 hospitalizations now. Our numbers, however, as you'll note, are not as high as what we saw in 2020, but they're significantly higher compared to what we saw this time last year. I do want to note the one very positive number here is that our deaths have continually gone down. You can see that since 2020, even during our surges. There is this common line of thinking that the pandemic is over and COVID is no longer of concern. But these numbers clearly demonstrate that COVID is still with us. Given both the increases in hospitalizations and the lack of certainty in the winter trajectory for COVID-19, continuing some common sense mitigation strategies that we know work to limit transmission and illness, including masking and being up to date on vaccines and boosters, remains a very sensible approach. The blue line on this slide shows the 7-day average number of deaths reported daily, and it's measured by the axis on the right. We're currently reporting an average of 8 deaths per day, continuing the stable trend we've been seeing since early November. However, a note of caution here because deaths are a lagging indicator, so we do remain concerned that these numbers could rise a few weeks from now as they have in the past after significant increases in cases and hospitalizations. I do want to take a moment to acknowledge the loss that's been felt in communities, particularly over the holidays, and to send my condolences to those who are grieving a loved one who has died. Next slide. Because it's important to separate out those individuals in the hospital with incidental infections who need hospital care for reasons other than treatment for COVID, from those who are in the hospital because they need care for COVID-related illness. This slide, which you've seen before, shows the proportion of hospitalized cases meeting the definition for COVID-associated illness from January 1st of this year through November 7th. Last January, during the peak of the winter surge, we saw that 60% of COVID hospitalizations were due to the need of treatment for COVID-associated illness. For admissions during the week that ended on November 7th, the number is 43%. From mid-February to the present, the proportion of COVID hospitalizations that were due to COVID-associated illness has remained relatively stable, ranging from 37 to 45%. We're currently towards the upper end of that range, and we know that this proportion usually increases during the surges. So it is possible that with increasing COVID cases this winter, we'll see an increasing proportion of COVID hospitalizations that are due to COVID-associated illness. Next slide. If we use the CDC community levels framework, this week LA County moved from the low community level to the medium community level. Today's case rate is 185 new cases per 100,000 people, and the COVID-19 hospital admission rate that pushed us into medium is now at almost 12 hospitalizations per 100,000 people. The proportion of staffed inpatient beds occupied by COVID patients also increased from 3% on November 17th to 5.6% this week. We do continue to see small but consistent increases for this indicator. Moving into the medium community level, there will not be changes to required mitigation strategies that we're currently using for COVID-19. However, it does signal that case rates and hospitalizations are elevated, and we could be in the high community level as soon as next week if the upward trends we are seeing continues. We just would need to, in order to move, we just would be showing a case rate of 200 cases per 100,000. Recently, the weekly number of reported cases has been increasing by about 4% each day. Given that transmission has increased significantly these past couple of weeks, we do appreciate that more people are masking indoors and using strategies such as testing and staying home when they're sick. Hopefully, our collective actions can reduce the associated disruptions and heartache that often comes with more illness spreading across the county. Cases are undercounted, as I noted, due to at-home testing and people not testing. And with hospitalizations up, health systems could be greatly affected. If both hospital indicators, the new COVID-19 admissions and the proportion of staffed inpatient beds occupied by COVID patients, surpasses the threshold for high, and our case rate is at or above 200 new cases per 100,000 people, LA County will follow the CDC guidance for communities designated at the high community level, including universal indoor masking. Next slide. Public Health consistently monitors 8 early alert signals to better understand potential changes in COVID-19 transmission. Due to schools being closed for the Thanksgiving holiday, the number of new outbreaks in K-12 schools is excluded this week. The impact of more transmission, as you can see, is felt across the healthcare system and among our vulnerable communities. 4 metrics are now of medium concern this week: the percent of emergency visits for COVID, the 7-day cumulative age-adjusted case rate in our lowest income areas, the SARS-CoV-2 wastewater concentration, and the number of new outbreaks in settings with people experiencing homelessness in the past 7 days. 2 metrics have moved into high concern: the percentage of new subvariants and sublineages of interest, and the number of new outbreaks in skilled nursing facilities. And while worksite clusters remains low concern, the significant increases in reported clusters these past 2 weeks, from 62 reported clusters to 128 reported clusters, does reflect the impact of increased community transmission at workplaces. Next slide. We do continue to pay a lot of attention to the significant role that emerging variants, subvariants, and sublineages of SARS-CoV-2 virus have had in driving our past surges and what the impact may be for our current COVID situation. The most recently available data for LA County shows that Omicron BA.5, and you can see that here, that's the red bar on the graph, is rapidly losing dominance. For our early alert indicator, we track BQ.1 and BQ.1.1, as indicated by the light pink and purple bars at the top of the graph. As a reminder, these are strains associated with BA.5. While individually these subvariants account for the 2nd and 3rd greatest number of sequenced specimens respectively, when you combine them, the BQ family of variants makes up 38% of specimens, surpassing BA.5, which is at about 36%. You can see this consistent pattern of BQ.1 and BQ.1.1 growth that began at the very end of September. Due to the time it takes for specimens to be sequenced and reported to public health, the local data shown on this slide always has a 2 to 3 week lag. CDC's national data has the same lag, but they can calculate predictions of the estimated proportion of each subvariant circulating now. These estimates show that BQ.1 and BQ.1.1 will likely continue to be the dominant variants in the United States. The CDC predicts that for the week ending November 26, BQ.1 and BQ.1.1 combined accounted for more than 55% of sequence specimens nationwide. And this prediction is slightly higher for Region 9, which includes us, in addition to Arizona, Hawaii, Nevada, and U.S. territories. I also want to note that small yellow bar at the top of the graph. This bar represents XBB. This is a combination of two other BA.2 subvariants. This subvariant first appeared in specimens in LA County on October 1st, and at the time it accounted for 0.1% of sequence specimens. As of November 22nd, XBB accounted for just over 3% of our sequence specimens. XBB has a mutation that's been linked to increased immune evasion, and that's why we're tracking it. It does warrant caution. This is the same mutation present in BA.2.75, BF.7, and BQ.1.1, among others. The green bars at the bottom of the graph represent BA.2 in the darker green and BA.2.75 in the lighter green, and you can see those also increased in these past week. However, we do expect over time we'll have some additional designations here because some of the sequences that are currently classified as BA.2 and BA.2.5 may be reclassified to be more precise BA.2 related sublineages, such as BN.1, once there's more data that's available. The take home, I think, is that the viruses change over time, and as they change, they try to evade built-up immunity and have the increased potential to infect more people. From what we've seen of COVID-19, this virus changes rapidly, and this is why we continue to see these new emerging variants. This means that even if you had COVID before, it's still important to take common sense precautions and do the things that we know work, including wearing a mask when transmission is high and getting the bivalent booster. The updated bivalent booster was specifically formulated to provide protection against Omicron BA.4 and BA.5, including their related sublineages, such as BQ.1 and BQ.1.1. At this point, you can see clearly that BA.5 in particular and the related sublineages are dominating. Sadly, the fact that only 16% of eligible residents had this booster and are getting this increased protection is something that we need to all work together to improve. We have about almost 6 million residents that are currently eligible and haven't yet taken advantage of this additional defense. Next slide. You can see on this slide the number of new outbreaks opened in skilled nursing facilities over the past 7 days has significantly increased. This graph begins in July 2022. That was during our summer surge, and it goes through November 29th of this year. The horizontal dashed lines represent the early alert metric thresholds for what's considered low, medium, and high concern. During the past summer surge, this number peaked at about 40 new outbreaks during the weeks that ended July 12th and July 17th. Sadly, for the week that ended November 29th, we're already reporting 44 outbreaks. Because residents in nursing homes are often older and in fragile health, they are more likely to experience severe illness from a COVID infection. I want to acknowledge and thank everyone working at our nursing homes for the extraordinary steps that they're taking every day to ensure that residents maintain a high quality of life. I also want to note that given the increased numbers of outbreaks, N95 masks for all staff in skilled nursing facilities are now required, and that we ask that visitors do a rapid test for COVID to be sure they're not positive before coming into the buildings. Public Health will continue working with all skilled nursing facilities to be sure they have access to respirators and antigen test kits for visitors, along with our continued partnership efforts to increase the number of residents and staff who have received the bivalent boosters. Next slide. We also continue to monitor wastewater to better understand the extent of community transmission, and this graph displays our wastewater viral concentrations of SARS-CoV-2. That blue line is the weighted average for viral concentrations across 4 wastewater treatment plants that cover most of LA County. The treatment plants included are Lancaster, Tapia, Hyperion, and the Joint Water Pollution Control Plant. And this reporting, as you can see, starts back at the end of May and goes through November 19th. For the most recent week, the viral concentration is at 59% of the peak concentration that we saw July during our summer surge, placing us in the medium concern category. But once this number surpasses 60% of peak concentration, this will place us in the high concern category. This climb is in accordance with the currently elevated case rates that I reported earlier. Next slide. Along with COVID-19, LA County, as is the rest of the country, is seeing high rates of flu and RSV. This triple threat, as you may have heard it called, has a lot of potential to cause there to be significant circulating illness and to strain our healthcare system, both in terms of the number of beds that are available and the number of healthcare workers that are impacted by illness, which lowers the hospital's capacity to take care of patients. On this slide, we track the current flu season and show the past 4 flu seasons for comparison. The calendar for flu monitoring begins in October and runs through September of the next year. On this graph, you can see the months along the bottom of the axis, and the axis on the left represents the percentage of specimens testing positive for flu. This week, 25% of specimens tested positive for influenza, and this is higher than the week before. You can see that with the red line. We continue to see an upward trajectory of flu cases testing positive, of flu specimens testing positive. Here in LA County, it's very clear that we're seeing very high levels of flu activity for this time of year. You could see that clearly, that we're like off the charts. And that we're continuing to see a sharp increase in the proportion of specimens testing positive for flu. Since any case of influenza can be severe, especially when it occurs in people who are at high risk, older adults and young children, our healthcare system can be impacted from this high flu activity level. And we already are seeing many individuals hospitalized for flu-related illness and complications. So please, we urge people to not just think of this as just the flu. It's not too late to get your seasonal flu shot, and the same measures that you're taking to protect yourself from COVID can be applied to flu prevention as well. Next slide. We also look at wastewater data on flu because it provides us with a second source of data, capturing information even for people who are not getting tested for flu. And here you can see the weighted average wastewater concentrations for influenza A, which is what we're mostly seeing, across the Joint Water Pollution Control Plant, Hyperion, and Lancaster sewer sheds. As you can see, in early October, wastewater concentrations began to rise, corresponding with what we consider the beginning of the flu season. The concentrations have continually increased with a steep upward trajectory. This data does confirm what we're seeing with the Sentinel Lab sequencing. And we're going to flip to RSV. This graph, similar to the last graph, begins in October and ends in September, showing data for the past 5 RSV seasons, including 2022 and 2020 through we'll go through 2023. The most current season of RSV is shown with that red line on the far left. Like flu, we started at a much higher level than usual. However, looking at this graph from the Sentinel Lab data, it appears that RSV may have peaked in early November, and that the percentage of tests that are positive for RSV are declining. This, however, could not be a real decline. It could reflect instead big increases in the number of individuals being tested for RSV. It's also important to recognize that the current percent positivity, even where it's dropped, still surpasses the highest percent positivity values seen for our last 5 seasons. So still an alarming number of people who are testing positive for RSV. Next slide. I also have some wastewater data for RSV. As with our flu wastewater data, this is the weighted average of RSV concentrations across the Joint Water Pollution Control Plant, Hyperion, and Lancaster sewer sheds. This slide paints a different picture from the previous slide that showed the percentage of specimens testing positive for RSV. In wastewater concentrations, we haven't seen, as you can see, any decline. Until we have data over a more extended period of time, we can't say with certainty whether RSV peaked. We do know that there could be multiple reasons for the differences between these two sources. It's possible and highly likely that many adults, not just children, are getting RSV and that they've had milder infections, meaning they're not getting tested, but that RSV infection is going to show up in wastewater. The length of viral shedding is also unclear, so the virus could continue to appear in wastewater after a person would no longer test positive at the lab. And last, as I noted earlier, there could be this denominator issue. More people could be getting tested for RSV as an extra precaution since respiratory infections are so high this season. Since RSV and flu are not measured by individual cases, rather we're measuring them by the percent of positive tests, the same number of positives could be a lower percentage of the total if more people are getting tested. Given the high levels of RSV activity, caution is warranted. RSV often impacts young children most severely and causes bronchiolitis and pneumonia. It's important to take precautions to prevent respiratory illnesses. This includes washing your hands often, and for RSV in particular, wiping down frequently touched surfaces. Also, please know that masks provide protection against RSV and flu the same way they provide protection against COVID transmission. Next slide. As we move into colder months and we're seeing these higher rates of COVID-19 transmission in our community, I do want to review what we should do if we test positive for COVID-19. It's important to test for COVID-19 if you have symptoms or you think you may have been exposed, so that you can be aware of what's going on with your body and take action as soon as possible when needed. There are times when people do test positive with COVID without any symptoms. Perhaps a person tests before a large gathering or upon returning for travel, and they have a positive result with an asymptomatic infection. This person can still spread COVID. So if you have a positive test, but you don't have any symptoms, it's important to still stay home, isolate from others, and rest. On day 5, people can retest, and if they have a negative COVID test, they could leave isolation starting on day 6, as long as they're wearing a well-fitting mask when they're indoors around others. Without that negative COVID test, the person should remain in isolation. Isolation can end after day 10 if you've been fever-free for 24 hours without the use of fever-reducing medications. COVID-19 symptoms can range, as many of us know, from a mild headache to a severe cough with shortness of breath. If you've tested positive and you're experiencing any symptoms, from body aches or a low fever to excessive fatigue or a sore throat, please check with a provider about receiving antiviral therapeutics to treat COVID-19. Paxlovid is commonly prescribed. This medication is in a pill form and you can take it at home. In clinical trials, Paxlovid significantly reduced the risk of hospitalization and death for people with COVID-19. And during these winter months, it's going to be super important to reduce the need for hospital care wherever we can. Many people qualify for Paxlovid, so I encourage everyone who has symptoms to reach out to a provider as soon as possible, because to be effective, Paxlovid must be started within 5 days of symptom onset. Your provider can screen your symptoms and risk factors, as well as make sure there will not be a negative interaction with any other medications you're taking. If you don't have access to a provider or you can't get an appointment, please call the Public Health Call Center at 1-833-540-0473 to access our free telehealth services. We also have test-to-treat sites where you can speak to a provider and receive a prescription. Go to ph.lacounty.gov/COVID medicines for more information. Finally, it is very important that we're all able to recognize severe symptoms and know when it's time to seek emergency care. A person should go to the hospital if they're experiencing troubled breathing, severe chest pain, a bluish discoloration of skin, lips, or nail beds, disorientation or confusion, or trouble staying awake. Next slide. As I noted a minute ago, if you're unsure about your symptoms, there is a safe and easy way to get consultation care and a prescription for treatment without ever leaving your house. Telehealth allows you to speak with a provider over the phone. If you're eligible for treatment and your healthcare provider recommends and prescribes it, A prescription can be called into your local pharmacy or overnight shipped to your house. Your regular provider may offer telehealth services, but if they don't, or you don't have a regular provider, again, please call our telehealth service 1-833-540-0473. We're open 7 days a week from 8 in the morning to 8:30 at night. And this service and all medications are offered free of charge. You do not need to have insurance to access the telehealth service. The COVID-19 infections hit some people hard, and we want to make sure everyone knows that this option is available. You don't need to leave your home, you can rest and recover, and you'll not risk infecting others. The important thing is that you contact your provider or you use the telehealth service as soon as possible after symptoms begin, especially if you're at higher risk. Next slide. In LA County, with the significantly increased transmission that I've been talking about, masking is now strongly recommended in indoor public spaces. When choosing a mask, the best options for protection are an N95 respirator, or a KN95, or a KF94 mask. A multi-layered surgical mask is a good second choice. As we've learned more about COVID and seen emerging variants that are more infectious, most cloth masks are not going to provide a lot of protection. Make sure your mask covers your nose and mouth and provides enough coverage to sit under your chin in order to form a good seal. You don't want there to be gaps around the sides or the places where you feel air flowing in and out. If you wear glasses and they're fogging up, that's a good sign that you probably need a better seal on your mask. A mask with a nose piece can help you adjust the fit. It's important that your mask is fitted, but also that it's comfortable so that you'll be able to wear it for long periods of time without wanting to remove it because it's too tight and too uncomfortable. You should wash your hands before and after handling your mask. You could use hand sanitizer as well. Use your ear loops to really put on and take off your mask. And if your mask or respirator is designed to be reused, you should allow 24 hours between your wears. If the mask you're using is disposable, you should use a new mask every day. For any mask or respirator, it's time to throw it away and to get a new one if it becomes wet, dirty, no longer holds its shape, has a broken nose piece, or the ear loops have stretched so far that you no longer have a good fit. Masking remains an easy strategy for reducing transmission of COVID-19, especially if you do it well. In closing, while there still is uncertainty about what the impact of COVID-19 will be this winter, there is mounting evidence that we are entering into another possible COVID surge. In some ways, this surge is likely to be very different. We know a lot more about COVID, we have great tools to help mitigate severe outcomes, and we're more aware of symptoms and when to take action. On the flip side, this will be the first winter where we're facing rising levels of COVID with emerging new strains, which we know less about, along with unusually high flu and RSV activity. I do encourage everyone to get an updated COVID-19 booster and your flu vaccine as soon as possible. You could ask your family and friends if they've received their bivalent fall boosters. We need to be sure that everyone knows that additional protection is available to boost our immune system response to COVID and to counteract that waning immunity from either previous COVID vaccines or from a previous infection. When transmission is low, layering protections is not as essential. With significant transmission, we'll need to continue to take the actions we know work. Indoor masking, frequent washing of our hands, staying home if we're sick, and testing before gatherings or travel. Together, we can continue to minimize the impact. I'm now happy to take your questions.
Questions? Go ahead, Ken.
Dr. Fair, could you repeat what you said earlier? I think you said LA County is now in medium transmission.
Yeah.
Next week likely to move high. And what are the implications for mask mandates?
Yeah, thanks. So I want to clarify. We have high transmission, but we're at the medium community level. So the medium community level takes a look both at transmission, but also at what's happening at your hospitals and how much stress you have at your hospitals. The transmission just looks at transmission. So transmission is high. You can see that in all the numbers. Once you get over 100 new cases per 100,000 people, you're at high transmission. But we are now moved officially by CDC from a low community level to a medium community level because Our transmission rates are higher, but more importantly, we have stress already at the healthcare system, and that is because the number of new admissions is now greater than 10 new admissions per 100,000 people. So that's what moved us to medium. But as I noted, the move from low to medium community level has no implication on our requirements here in LA County. It has more of an implication on us all being aware that we need to be more careful. But it doesn't change any of our health officer orders. Our issue right now is we're sort of accelerating in a move over to high. So I would anticipate that sometime in the next week and maybe in the next few days, depending on our case numbers, we could be moved by CDC as soon as next Thursday into that high community level. When we're in the high community level, we'll be adhering to CDC's guidance as long as both of our hospital metrics meet that high threshold, not just one. So right now, one metric, the sort of rate of admissions, is sort of in that high category already. But our other measure, which is the percent of beds that are occupied by COVID patients, actually remains at about, I think I said today, we're at a little over 5%, 5.6%. So again, we would need both of those metrics to also be at the high level, along with our case rate to be at the high level. And then we would go ahead and follow the CDC guidance, which includes universal indoor masking.
Okay. And
Does that explain it?
yes, and just two-part follow-up.
Okay.
What's the likelihood of that threshold of both triggers being
Yeah.
changed next week? Number one, and number two, can you reiterate what the universal masking means
Yes.
to those of us who are familiar with it?
Yeah, thanks. I do not think by next week we'll have met the second hospital metric moving into high. We're like 5.6%, and if you sort of look at the tables we share every week with you, you'll see that number has moved much more slowly than the number of new admissions. So I anticipate that it could get there, later in the month of December, but I don't think it'll be there next week. I'd be very surprised. I mean, it would mean that hospitalizations are really going up very, very quickly, much more quickly than we usually see. We have protections to keep people out of the hospital. So that's why you heard me stress, please get your therapeutics, please, talk to your provider, keep yourself from getting those severe symptoms that would then require a hospitalization. If we do move into high and CDC maintains their guidance, because again, we're aligning with the CDC guidance on this, we would ask for universal indoor masking. And for those of you who may be unfamiliar with that, that is where wherever you go indoors, we ask that you keep that mask on.
Does that
Oh,
mean
and it
this
is.
is a requirement?
Businesses, it would be for businesses, for schools. We would be back to saying our healthcare system is getting stressed out. We need to slow down transmission. And as we've done before, as soon as we see that, our hospitals are no longer stressed, as soon as our metrics come down, we would lift the universal masking protections.
Thank you.
So
Marla?
it seems likely then that we will get that mandate from you, maybe not next Thursday,
Yeah.
but certainly by Christmas time,
Well,
if the numbers trend up. So
Yeah.
if that's the case and we do get that universal indoor mask mandate, what's the difference between now versus the summertime? Beyond that, we're now in winter versus summer, because we had higher numbers in July when you didn't reinstate the indoor mask mandate.
no, I mean, we've always had the indoor mask mandate when we've been at the high community level, when, as designated by CDC. The change that we made is the threshold that CDC sets is just to meet one hospital metric, and now we believe we need to meet both hospital metrics. Like, our system is not necessarily stressed. The healthcare system is not necessarily stressed when we just see a lot of admissions. So that percent of beds occupied by people with COVID is actually significant, and we'd need to see that we reach both of those metrics in order to go ahead and ask people to do universal indoor masking.
But the likelihood is high.
Well, we're puzzled, frankly, by this rapid increase in hospitalizations. And I know Dr. Davis is meeting with a lot of the hospitals today to actually talk about sort of the stress on the healthcare system right now. and what their strategies are for coping with the stress. Because remember, we're not even counting in the stress of influenza or RSV on the hospitals. But it's going to be super important for all of us. If our healthcare system experiences a lot of stress, we're all at very big risk. Car accident, people who need coronary heart disease care. I mean, hospitals systems being at stress, something we've experienced twice now, and something we don't really want to experience again. So we'd like to make sure that we do everything we can as a county to take some simple steps to get transmission down lower. People don't end up in the hospital if they don't get infected. It doesn't happen. They don't end up in the hospital for COVID if they don't get infected. So it's the same thing. You don't get infected with flu, you're not going to end up taking up a hospital bed. So we got to do whatever we can right now. We've got this window. I've personally been pleased. I've seen a lot more people wearing their masks. I think people are scared of RSV and influenza as well. And I also think people don't want the disruptions. I'm going to be honest, we had more people report to us positive COVID tests after they came back from Thanksgiving than we've ever had before. So there just is a lot of transmission that's going on, and it ends up being disruptive, and we've had a fair number of people that are pretty sick. So we're going to urge people, let's do what we can. Let's try to minimize disruptions and certainly minimize, causing unnecessary stress on the healthcare system.
Have you talked to other, if I may, have you talked to other local health directors? Because obviously we're not alone.
Yeah.
COVID numbers are
Yeah.
rising elsewhere as well. And
Yeah.
so I'm curious if in fact, we do have a universal mask mandate
Yeah.
again, and we're on an island of our own.
Yeah.
Your reaction to that and pushback
Yeah.
you may get from the public.
Yeah, I had a good talk with Dr. Aragon this morning. He's the director of the California Department of Public Health, about exactly that. What are you seeing? We feel like we're seeing a much more rapid acceleration than we wanted to be seen at this point. And I was asking him, what are your models predicting? What are you seeing in other counties? Are we unique? He did say he would try to share data with me later today or tomorrow so that we can, in fact, look at whether this is unique to LA County. But I think what he did share was that they're equally concerned because of the triple threat that our healthcare system could really face some very difficult times ahead.
Okay.
So considering the many studies that show the low efficacy of reducing transmission for single-class masks, are we to assume that if the indoor mask mandate, especially for school children, goes into effect, that you'll only be requiring a cloth mask? Is that correct?
It's a good question. I don't think we've thought that far ahead, to be honest, about the requirement. Any kind of mask works better than no mask. I think it's our job to do a much better work educating everybody about the importance of upgrading your masks. We have our community health workers out there. Part of their message is not just to get boosted and vaccinated for flu, but also to understand why you should upgrade your mask. We still see people who wear a mask under their nose. I think you probably see the same. And it's just important, for those who are making the effort to use a good, high filtration, well-fitting mask for it to have the most impact.
We have several messages sent in from Jackie Fortier at KPCC.
Okay.
Can you describe the situation in the hospitals? Tents are already being used in San Diego to ease ER triage. Can we expect the same in LA? And then also, question about masks. Offices often don't implement mask mandates until there is at least one COVID case. Given the increased community level, do you recommend that offices and businesses require masks for their employees?
Yeah, thanks, Jackie. Great questions. In terms of the hospitals, we're tracking, obviously, occupancy across LA County. And, it's high. For adult beds, we're at 80%. And again, I want to note that when staff go out sick, you may have a bed, but you don't have a staff person there, so you don't get to use the bed. So hospitals are pretty full. ICU's pretty full. It's at about 75%. And again, pediatric hospital beds and pediatric ICUs and PICUs are also, NICUs are also pretty crowded. So I think there is, even here in LA County where we don't have an emergency and we still do have beds and capacity, there are issues. I know Children's Hospital particularly struggles around transfers because they have a lot of their own patients. This is why I know nobody is anxious to hear this message from us that we need to protect each other again. But we cannot take actions at this point to help our healthcare system. We have to do it now. We have to really make sure that we're able to do everything we can to reduce the number of people that are going to need a hospital bed or an emergency department or a care in an emergency department because they're really sick. Because that hurts everybody when our hospitals are so stressed out. So we have some hospitals that I think are setting themselves up to be able to do a better job on triaging and move patients into particular areas more quickly. But at this point, we do not have here in LA County an emergency situation. And people, I think it's really important that people who are very sick know that they should go to the hospital. I want to sort of really emphasize our emergency departments are open. They're open for people who need emergency care. Please don't go there if it's not an emergency. But for people who have an emergency, especially with this much respiratory illness circulating, we want them to be secure that when you need emergency care, the hospital is the place to go.
The other question from.
Oh, then the other question.
Offices and masks?
Yeah. So, we have a strong recommendation. I think it depends on your setup in your office. A strong recommendation means we think everyone should be wearing a mask. There are some offices where they've had a lot of outbreaks, and I appreciate that they've gone ahead already and just said, we're so much there's so many different viruses circulating. We have so many people out. We're just going to tell people as they come in to go ahead and put those masks on for additional protection. I think that's wise, and I think it depends on your individual circumstance. There are other offices where people are quite separate from each other, and sort of the strong recommendation is really for those who are going to be in indoor spaces in close contact with others.
I had a. Go
¿Puedo
ahead.
decir algo en español? Me parece importante el hecho de que hay muchos más casos ahora con respecto a la misma fecha del año pasado. Mucha gente piensa que se acabó la pandemia. Si puede comentar de eso. Y también me gustó lo que dijo que hay 6 millones que posiblemente pudieran tener la vacuna en el condado y no la están agarrando.
Sí, tú sabes, la data es la data y dice que aquí en el condado de Los Ángeles tenemos mucha gente que están enferma con COVID todavía. Esto no ha pasado, todavía tenemos bastante gente, millones de gente, que de veramente no tienen la protección que necesitan para asegurarse que si el virus, si estás infectado con el virus, que no vas a necesitar ir al hospital porque estás bien enferma. So, para nosotros es bien importante que la gente sacan el booster. Es un nuevo booster, es una nueva vacuna. Mucha gente cree que, tú sabes, ya en enero saqué otro booster, pero este es uno nuevo y todo el mundo necesita sacar la nueva vacuna. Okay.
Go to Marla, and then we have some questions from Ron Lynn as well. Go ahead.
Okay.
About the bivalent booster,
Yeah,
16%?
16%.
16%.
16%. So,
It hasn't really picked up.
yeah, we were at 12% a couple of weeks ago. We're doing better. It's for older people, it's higher, and that's a good thing because older people are at higher risk. But it's nowhere near the numbers we need it to be at.
Do you fear that you and the department have lost credibility with the public?
I'm not sure about a loss of credibility. I mean, I think lots of people still pay attention to us and listen to information. I think there's a lot of confusion about whether or not you need another booster. And I think that it's been particularly hard because we have a lot of folks saying, the pandemic is over. So if the pandemic is over and we're saying, you need a booster, people are saying, well, probably not because there's not as much risk. I do think as we've gone back to our customary activities and ways of engaging with others. And we've been doing this, in this pandemic for many years now. People have also lost interest in following the data on the pandemic. So one of the bigger issues I think we have is that most people are not aware that we're seeing increases in cases, that we're seeing increases in the number of people that are being hospitalized, and that this would be the time to take action before it disrupts your own family or your own gathering or your work site. So I think it's more of, this is a long-term pandemic. We're into year 3 almost, and people appropriately are trying to balance getting back to customary activities with trying to stay safe, when in fact we all know there's less risk now because we have all these protections that we can use than there was when this started.
2 questions from Ron Lynn at the LA Times. Is there a situation where we would see a mask mandate on public transport and airports, but not other indoor public settings? And then the second question is, how long would we need to be in the threshold for both metrics for the high level for a new mask order to be implemented? Immediately, or will we need to wait a few weeks?
Thanks, Ron. So I think in terms of mass transit, public transit, I believe that if there's going to be a separate requirement, it will come at the federal level, because I think there was a court decision that may give more flexibility at the federal level for them to go ahead and do that requirement at the federal level, which of course would be much easier to implement. In terms of the second question, we probably will do it the same way we try to do it all the time, which is we'd make sure we really were staying in high. So we would have a couple of weeks to make sure the numbers were stable and we're not just sort of at the edge of something. We'll have to sort of look at the rate of increase and what we're seeing in terms of that to decide what that time frame would be. And then, as we've done in the past, as soon as we feel that we see the numbers that show us that transmission has lowered and that concerns at our hospitals are lower and we're moving back into medium, we'd go ahead and lift.
Anything else from the room?
So, just for clarification on Ron's question, then, so say metrics are met next week, then you would say 2 weeks later?
Probably.
Universal indoor mask mandate would go?
Yeah, I mean, everybody needs time. Businesses need time. We've got to make sure, that, everyone's prepared. I want to note that employees remain required to offer employers remain required to offer their employees masks at this point. So hopefully all businesses have those masks. But we would give everyone time to go ahead and implement and for us to do education. And, again, compliance on universal masking has always relied heavily on people doing the right thing. So we have to do a lot of education to make sure people know. And as you noted, less and less people are paying attention to issues related to COVID. So it will take a bit of, I think, work and time for people to understand that the risk has really increased to the place where the healthcare system is stressed.
My last question is, what does the world look like in terms of where you would feel comfortable not having to take that step of putting a mask mandate into effect? We're in the third winter,
Yeah.
People are 40%, 35 to 40% of hospitalizations are there for COVID.
Yeah.
The vast majority are not. So
Yeah.
what world does that look like to you that you would say, we're in high, it's COVID's here, we're going to live with it?
Yeah.
It's up to the people to choose.
Yeah. I mean, I want to just reiterate that we are following the CDC guidance about what to do if your community level goes into high. So it's not, I know sometimes it gets painted as like you're kind of making this up here in LA County, as this is what people should do when we're in high, but we're not. I mean, CDC agrees with us, and we agree with CDC, that a reasonable action for everyone to take when you do go into high and you start seeing stress on your healthcare system is to go ahead and mask up, because it's a quick way of trying to reduce transmission when in fact you see that there's risk on the healthcare system. The one thing I am hopeful about, and I noted, is that the number of deaths have dropped pretty dramatically. And this will be our first winter with a lot of therapeutics and easy access to therapeutics. So I think that could make a difference. And if we started seeing data that really showed that the hospital system is not going to be stressed out, because we're really reducing the number of people that are getting hospitalized with severe illness, and we're also reducing the number of people who are dying, we would feel much more comfortable.
Thank you.
Thank you. I think we're done. I
I
could,
have one more question.
oh, okay.
Does the does the LA Health Department condone China's zero COVID policies?
You know, I mean, it's not our place to really comment on other countries and their policies. And you know, it's super complicated, even in this country, to make good decisions. As always, we appreciate that governments have an understanding and obligation to keep people as safe as possible. We also appreciate, as you've seen here, the need for people to have the resources that are necessary for survival and to thrive. So we will let China work on their policies while we work with all of you on our policies here.
Thank you.
Thank you.
Thank you.
Thank you.